This program is brought to you by Emory University.
Last week, for those, or this wasn't last week, it was 2 weeks ago, we talked about STEMI, and we talked a little bit about non-STEMI. The main thing we kind of really started into was the use of heparins and the lack of use of GPIs upstream, and the sort of new thought is the lack of P2Y12, so lack of Clopidogrel, lack of Prasugrel upstream. We're going to talk more about antiplatelets today. The other thing, reminding not to use morphine, to use nitroglycerin, and then if people are still having pain, they need a cath. And then we talked a little bit about troponin. We did not talk about high sensitivity troponin and sort of the definition of type 1 versus type 2 non-STEMI. So that led us to here. So if people are having, if people are in shock, pulmonary edema, they're on a nitroglycerin drip that's being actively titrated, these patients need to go to the CCU. And if they're having ongoing chest pain, ongoing ischemia, or they're still in shock, that is not a let's cath them tomorrow, let's cath them 72 hours from now. That is a cath immediately. The guidelines say it's immediate, on admission, at presentation, within 2 hours. 2 hours is quite arbitrary. This is a STEMI equivalent of going to the cath lab. It's class 1 for ongoing active angina or hemodynamic electrical instability. So the patient keeps getting shocked, if they're in shock, or if they're having chest pain, and you think that chest pain is angina, the patient is actively infarcting, that is an emergency. So anyway, I often see people kind of do this a little bit cavalier. When you get called for a non-STEMI, quote unquote, non-STE-ACS, the first question, the only question you want to ask somebody, if you're called about this, is the patient having active chest pain? If the patient's having active chest pain, that's not I'll wait a minute, I'll come down and see him in the next hour. That's an immediate go to the emergency room, immediately grab the nurse, immediately get the patient on nitroglycerin. And if you're not pain-free in 15 to 20 minutes, you're immediately calling the cath lab or the interventionist to think about an emergency cath. Don't give morphine. Now, the question is how do you know that this is ongoing active ischemic chest pain from all the other active ongoing bogus chest pain? That's the trick. And that's where the things that you need is you need hopefully a early troponin, a delta troponin. You could get a delta troponin at 90 minutes. 90-minute delta troponins that are going up, that's a concern. If the first troponin is elevated and there's active pain, that's concerning. The third thing to do is to get a bedside echo. If you got wall motion, that's concerning. So those are the ways to kind of think that maybe active chest pain could be an emergency. So anyway, this is not a, take your time and you've got hours and hours and hours. This is an immediate emergency. This is the equivalent of a STEMI. Now, if you don't have shock and all these active pains, then that's who goes to our cardiac floors. And then you look for intermediate or high risk features. And if you don't have those, then you do some sort of non-invasive testing. Really, these patients should not be in the hospital, so this should be a rare thing. What is intermediate high risk? This is straight out of the guidelines, but it probably still is reasonable. Those with recurrent angina, if they go up and they walk to the bathroom and they get chest pain, if it's elevated troponin, if you think the ST depressions are ischemic, if you think that they have heart failure that's ischemic, not all heart failure, but if you think ischemia is the cause of their heart failure, if you have positive stress tests from before, but you treated them conservatively, if there's hemodynamic electrical instability, all these things, these are the ones that you should be thinking about early cath. Most of the patients are coming in to the hospital or getting an early cath, otherwise they'll be going to the CCU. So those are the patients that need early cath. It's a class 1 indication for early PCI for intermediate to high risk. And that's because there's been a lot of strategy trials. Just remember, this is not that all these trials up here, these aren't courage trials. These aren't ischemia This isn't, Berry 2D. This isn't medical therapy versus intervention. This is a strategy trial of early cath versus early conservative, usually doing a stress test first. So in a conservative arm, they're not being managed conservatively. They're coming to the cath lab and getting intervention about 40 to 50% of the time. An early cath strategy means you just cath everybody, and about 70% of the time you'll find disease, but 30% of the time you don't even find disease. Remember, an early invasive strategy it only leads to revascularization about 60, maybe 70% of the time. Conservative still leads to revascularization, 40 to 50% of the time. So you're comparing, revascularization 70% versus 40 to 50. And what you find is that you still see a benefit in early follow-up with regards to recurrent myocardial infarction, hospitalizations, and probably mortality. This mortality benefit in meta-analyses seems to go out to about 5 years, but then due to crossover, is lessened. But anyway, patients with non-STE-ACS, they do derive a benefit. These aren't, so don't be thinking, I just heard about the ischemia trial, or I read the courage trial. You can't apply those trials to this population. Different. And just remember, this isn't medical therapy versus PCI. This is strategy. This is conservative with stressing versus invasive. And you end up with a fair bit of revascularization in both arms because of the way the trials are designed. So this is a lot of revascularization versus a moderate amount of revascularization. That's the way to think about it. In the cath lab for non-STE-ACS, if there's a large thrombus burden, we'll still add tirofiban. So here's a picture of a cath, the right coronary, a tight lesion. See this hazy area here? This is a big goober, a big thrombus. A lot of times we'll add a GPI in these situations, treat it kind of like it was a STEMI equivalent. The guidelines, 2A indication to use GPI in non-STE-ACS. So it's reasonable to add it to both aspirin and the P2Y12 inhibitor. But for most patients with non-STE-ACS, we're just going to keep them on heparin if they're small or troponin negative. You guys probably don't even see bivalirudin. When I was a fellow, bivalirudin was the craze. And actually, if you still go out and practice, it's about 50-50 in PCI. There's still a lot of bivalirudin use out there. So there are some people who might write some questions. You won't get them from an Emory doc, but you'll get them from other docs who like bivalirudin. Just know bivalirudin was sold as a drug that led to less bleeding complications in heparin compared to heparin. So people thought it was a safer way to do PCI and unstable angina and non-STEMI. But what we've learned, I think, over time is that benefits is pretty marginal or non-existent. This is the matrix trial, the randomized bivalirudin to heparin. Here's the look at it. The bottom line is there's really no benefit to bivalirudin. There was even some trials that looked and said, well, you don't want to give everybody bivalirudin, but if you had a really high bleeding risk patient, then you should try bivalirudin because you'll have less bleeding. That's exactly what NAPLES did. They did this bleeding risk score, and they calculated your risk of having a bleed. And then if your risk was really high, you got randomized to heparin or bivalirudin. And what it turned out is bivalirudin didn't reduce bleeding even in that high-risk population. So I think this has really led to, at least in our view, it to be out of favor. It doesn't really improve outcomes. It's very costly, and so we don't use it. So this is where we'll spend a little time today, and we'll go through some DAPT, and we'll just see how much we get through. Please stop me if you have questions or if you hear something that doesn't sound right, or, if you're seeing, doesn't fit with what we're doing. I'd be interested to hear. So please, just chime in and ask a question. We're going to talk about Prasugrel, Ticagrelor. So Prasugrel, it's a P2Y12 antagonist. It is a prodrug, so just like Plavix, it requires metabolic activation, but the activation in the metabolism is much more efficient, and it's not reliant on the CEP2C19 allele, which we'll talk about a little bit later. So Prasugrel was compared to Clopidogrel in a very large trial called Triton-TIMI 38. It was almost 14,000 patients. A couple things about it. They were very high risk. They were going ACS, and they were undergoing PCI. So the randomization really occurred in the cath lab after the anatomy was defined. They didn't randomize them upstream before the cath lab or downstream after the stent. It was in the cath lab with anatomy defined. So that's a big issue in this. And so you have to kind of think about how these results compare. What they found is Prasugrel reduced the events compared to Clopidogrel. If you look at this impact, it's about a 2% absolute benefit. So a number needed to treat of about 50 to be better for Prasugrel over Clopidogrel. There was higher bleeding with Prasugrel, and it was about a 0.6% increase in major bleeding. So a 2% absolute benefit, 0.6% increase in harm. I tell you those absolute numbers because I'm going to show you data that looks exactly like that with Ticagrelor. Unfortunately, in Prasugrel, they looked at a lot of subgroups, and one subgroup fell out, and this is, I think, unfortunate. Those that are over 75, body weights that are low, or a history of stroke or TIA. And in fact, there was harm if you had stroke or TIA, so it led to a class 3 indication and a black box warning to not be used. So it's contraindicated in stroke, TIA, and it's suggested for a dose reduction if your body weight is really small or 75. This is reasonable to do 5 milligrams for those that are low body weight and over 75. You know, from a clinical standpoint, does it matter if you give somebody with stroke Prasugrel or Ticagrelor or Prasugrel? No, they're probably both just as harmful. They're both just as bad. This is a medical legal question. Prasugrel has a black box warning. Ticagrelor does not. It's in the guidelines to be class 3 for Prasugrel. It's not in the guidelines for Ticagrelor. This is a stupid play of chance. It is what it is. So anyway, we just got to remember to do it, not because we treat patients, but because we're treating the lawyers of the patients. So don't give it to, so you don't get any lawyers involved for stroke or TIA. Ticagrelor, it is a direct acting drug. It's not a prodrug. It does not require metabolic activation. So that's a little bit different, as very rapid onset, and it's considered to be reversible in that it's faster offset, which has, I think, cuts both ways. It is a little bit beneficial in that if you needed surgery, it will wear off quicker. If you have a non-compliant patient, it will wear off quicker, and you would have problems if you're a non-compliant patient. So you have to look at Ticagrelor cutting both ways as being good or bad with its offset. So it was studied in the Plato trial, very large trial, Clopidogrel versus Ticagrelor. A couple things about this: the randomization included medical therapy patients, not just the PCI population, and the randomization started upstream, not at angiography. So there was preloading with Ticagrelor, and there was preloading with Clopidogrel, and there was medically management of these patients too. And what happened is there was a 2%, again, exactly the same as Prasugrel, benefit to Ticagrelor over Clopidogrel. And where the reps got us, and the reps went around and told all the doctors, and the doctors believed them, that there was no more increased bleeding because they used this Plato bleeding definition. So they said there was absolutely no more bleeding. So it looked like you had your cake and eat it too. It's a great drug. It was beneficial without bleeding. But the thing is if you go back and you actually look at the way the bleeding was defined with Prasugrel in the Triton trial, which was TIMI non-CABG major bleeding, not only was there more bleeding with Ticagrelor, it was exactly the same increase in bleeding. So when you take Plato at face value and you take Triton and you look at Clopidogrel versus Ticagrelor, Prasugrel versus Clopidogrel. So Prasugrel and Ticagrelor both have a 2% absolute benefit reduction in MACE and a 0.6% increase in bleeding. They're the exact same drug in terms of efficacy and safety. That's the takeaway, at least in these two major trials. However, with that, and if you think doctors aren't sheep, they are. We all are. Me too. Everybody. We get sucked into this, and with this data, Ticagrelor took off and became the market leader, and Prasugrel crashed, and we hardly ever used it, and that's unfortunate. The guidelines for non-STE-ACS, or at least for DAPT, recommend for non-STE-ACS and STEMI, so for ACS, that it's a 2A indication to give Ticagrelor and Prasugrel are preferred over Clopidogrel. So they're the preferred agents, Ticagrelor and Prasugrel, based on those two trials, which is very reasonable. Well, which of those is better? Remember, I told you Ticagrelor became the market leader and really took off and was used by everybody. So finally, we started to get some head-to-head data. And the first was the Prague 18 trial. It was a STEMI population, 1,200 patients. They randomized Prasugrel versus Ticagrelor. Head-to-head, the only variable was which one you got. And just like you'd expect, there was absolutely no difference. In fact, they had to stop the trial for futility because they realized that statistically they weren't going to be able to show anything. And when you looked at death, bleeding, and myocardial infarction, it was the exact same outcome, whether you use Prasugrel or Ticagrelor. What's interesting is even more recently, a really good group, the ISAR group, did the ISAR React 5 trial. And it was a bigger trial, 4,000 patients, and it was ACS population randomized versus Ticagrelor to Prasugrel. And their thought was that the bleeding would be better with Ticagrelor, was the hypothesis. And interestingly, it was not only a randomization of the drug, Ticagrelor versus Prasugrel, but it was also a randomization of how they were being used. Ticagrelor was being used in ACS on admission upstream, and Prasugrel was given in the cath lab. So this was sort of a double trial. It's a trial of upstream versus non-upstream, and it's a trial of Ticagrelor versus Prasugrel. The thought was Ticagrelor will be safer. But what they found is when they looked at safety, there was no safety signal. In fact, it was trending at all slightly against Ticagrelor. So there was no benefit of using Ticagrelor with any safety. And interestingly, then when they looked at the efficacy signal of death, MI, stroke, Prasugrel actually was statistically better. Now, I don't know if this is really true, but together it says that Prasugrel is at least as safe and better than Ticagrelor based on this randomized trial. And now there's a meta-analysis that puts head-to-head Prasugrel versus Ticagrelor in almost 7,000 patients from 6 randomized trials. And if you look at myocardial infarction, it's statistically similar, but trending towards Prasugrel. If you look at stent thrombosis, it's statistically similar, but very strong favor. I mean, very, very strong trend, almost statistically significant 40% relative reduction. So, really giving it, not a clear benefit, but a clear trend or strong nod towards Prasugrel in terms of those reductions in early events. And then when you look at bleeding, absolutely no price to be paid with Prasugrel compared to Ticagrelor. And if you look at mortality, again, mortality trending, it's not statistically significant, and I don't want to put too much in this, but if you look at that slight more benefit and not a lot of bleeding risk, again, trending at least in the mortality direction. I don't want to put a lot in that these are non-statistically significant. You shouldn't, say that they're statistically significant, but the trend is that it's at least as safe and maybe better. That's, I think, the takeaway for Prasugrel over Ticagrelor. The other problem with Ticagrelor is it causes dyspnea in about 20% of patients. So 1 in 5 patients will have dyspnea. So you just took a person, you did PCI, And then they're going to, then about 20% of your patients, they have some sort of discomfort or, a feeling that they don't, it's not right with the shortness of breath, and it makes it hard to see. Is this heart failure? Is this a allergic reaction? Is this ischemia? And it leads to a lot of stuff and a lot of extra downstream treatments and just confusion, and the patients are confused and the docs are confused and everybody's just confused. And it's much less if you use placebo or Clopidogrel or Prasugrel. So another trouble with Ticagrelor. And Ticagrelor is twice a day, whereas Clopidogrel and Prasugrel are once a day. So which is better? I think today the data is pretty strong in favor of Prasugrel. Prasugrel is now generic, and so it's not as cheap as Clopidogrel, but it's really close. In fact, if you go out and start looking and get on goodrx.com, you can find it for somewhere between $5 to $20 a month, depending upon the pharmacies. You do have to look around a little bit. Not all places, it's still a little bit of an issue, but it's much, much, much cheaper than Ticagrelor. And it's so cheap now, like for Grady, we can get a 90-day supply for $10. So we're really trying to get our patients to go out the door with a meds to beds with a 90-day supply of Prasugrel. And so Prasugrel, it's cheap compared to Ticagrelor. It's once a day. It doesn't cause dyspnea, and it may be better, and it's at minimum just as safe. So it's a pretty good drug. I think we're really moving towards Prasugrel. I'll tell you, we just looked at our data in the Emory system, and 80% of our patients are getting either Clopidogrel or Ticagrelor in the last year in ACS. So we've got a long way to go to really walk the walk and talk the talk. We say that this is what we think is the right thing to do. We're not doing it. And so that falls on you guys listening. You got to help us move the needle and start sending the patients out on Prasugrel and ACS. Now, is there a role for Clopidogrel? I'll tell you, Clopidogrel is my favorite drug. And I'll go through this why. So remember, we said that Clopidogrel is recommended against Ticagrelor and Prasugrel in ACS. And there are, it's based on good data. Clopidogrel is a prodrug, and a lot of it goes to an inactive metabolite during its metabolic activation, and it is a slower metabolism compared to Prasugrel or definitely to Ticagrelor, which doesn't require metabolism. What's interesting is that when we know that not everybody can metabolize Clopidogrel equally, and there are patients who have a genetic abnormality in the CEP2C19 reduced function allele, and this represents maybe a quarter to 30% of the population have either or heterozygous or homozygous for this CEP2C19 reduced function allele. The flip side is to say the vast majority of the population is not a reduced function. It does not have problems metabolizing it. And what's interesting is then when you go back to remember the Triton trial that showed Clopidogrel was inferior to Prasugrel, and you go back and you do the trial over again, but subdivide it based on their genetic response. What's interesting is if you are a genetic responder and you can metabolize Clopidogrel, Clopidogrel is the same as Prasugrel. So I don't want you to think of Clopidogrel being a weaker drug than Prasugrel. It is not a weaker drug. It is the exact same strength as Prasugrel, the exact same strength as Ticagrelor. When you look at death and bleeding and MI, the numbers are almost identical. The reason at a population level that Clopidogrel looks worse is not because it's a worse drug. It's only a worse drug in those that can't metabolize it. And so the benefits that you see of Ticagrelor and Prasugrel is driven by this group. And remember, I told you the number needed to treat with Prasugrel was 50 in the trial. Well, the number needed to treat in the non-responder. So if you randomize a person who doesn't metabolize Clopidogrel well randomize that patient to Prasugrel. Not only is Prasugrel better, but it's way better. And the number needed to treat is actually quite small. So it becomes a much, much, much better drug compared to Clopidogrel in the non-responder population. So the whole benefit that you're seeing of Prasugrel and of Ticagrelor is driven by those who Clopidogrel doesn't work. So it is important because this is a third of the population. So you hate to be sending a third of your patients out on a drug that doesn't work as well when there's a better drug out there for those patients. So there are now some data that suggests maybe if we were genotyping our patients like this, we could get better outcomes. And so this was the popular trial published in New England recently. 2,500 patients. They were STEMI. They got randomized to either being everybody got Ticagrelor or Prasugrel, or the other group is they genotyped them. They gave them Prasugrel. They checked if they were a genotype, and if they were okay to take Clopidogrel, then they switched them to Clopidogrel right away, right out of the bat, right out of the gate, so they went home. So 70% of this group went home on Clopidogrel, 30% remained on Ticagrelor and Prasugrel, and then this was compared to giving everybody Ticagrelor and Prasugrel. And you can see that there was no benefit to standard or universal Ticagrelor or Prasugrel. In fact, the trending was towards genotype driven. And if you looked at the bleeding outcome, and this was both major and minor bleeding, and this was really driven by minor bleeding, actually Clopidogrel or the genotype guided group did better. And what that probably represents is that, for major events, they're pretty similar, but there's probably less nuisance bleeding with Clopidogrel compared to Ticagrelor or Prasugrel. So in terms of if you were a patient and you're going to take a drug for a long period of time, most of what you care about is dying of bleeding and dying of a stent thrombosis. So that's good news is that's all the same. But you also don't like bleeding every time you shave, or bruising everywhere, or bleeding when you stub your toes, or all the stuff. And it's just a little bit more pleasant to be on Clopidogrel probably for life than it is for Prasugrel or Ticagrelor. Now, there's other ways to look at how Plavix works. So one is a genetic approach. You see if they have the alleles, but you can see that, you can imagine that there's other things that go into whether Clopidogrel works. It's not just their CEP2C19, but there's other genetics. There's how it absorbs, whether they get narcotics, morphine, fentanyl, all delay the absorption, clinical characteristics, drug distribution. So there's more to it than just whether they're a genetic responder. So a lot of other people say, well, let's not test upstream the genetic. Let's actually see if the platelets are being inhibited with the Clopidogrel. So we can test that with Verify Now platelet function testing, and it measures platelet-induced aggregation, and this is expressed as P2Y12 reaction units, PRU. So it's really a marker of inhibition or a marker of platelet aggregation, and as the PRU goes up, you're getting more aggregation and less inhibition. So above a certain level is considered inadequate inhibition. So there's some debate in the literature of what that cutoff is. We've used 235 in the Emory system, and I think that's probably where the majority of the data lands. Just so you know, there are other numbers like 208 gets thrown out from some other trials. So in your mind, if you wanted to consider 208 to 235 a slightly gray area, I'm okay with that, because what's normal is different depending upon it. The other thing that's nice about platelet function testing is it's a continuum, right? 235 is worse than 234. 234 is worse than 233. So it gives you a spectrum. Somebody might be 5, somebody might be 100, somebody might be 200, somebody might be 300. Those are very different patients. And so it gives you a continuum. It's not just a yes, no, right, wrong. So some people like it for that continuous variable, but the more continuous the variable, the more troubling it can be to sometimes make the decision. Some other people just say, give me a yes, no answer. Tell me the genetics. Is it genetic yes, genetic no? Okay, I'll change. So anyway, there are data that suggest platelet function testing is just as good. This is a moderate-sized trial, ACS, randomized to platelet function testing. Again, it's kind of a confusing design. Everybody got Prasugrel early, then they took half the group off of Prasugrel, let it wash out. They put them on Clopidogrel, and then they tested the Clopidogrel to see if it works. And if it worked, they stayed on the Clopidogrel. And if it didn't work, they went back on Prasugrel. So confusing. You'd never do that in clinical practice, but that's what they did. And they published this in Lancet. And the bottom line is it was at least as good. It was non-inferior, and again, trending towards superior of a strategy. Really, again, less minor bleeding with the Clopidogrel strategy. Just as good protection with Clopidogrel when it works. So I say those. I show you a genetic study. I show you a platelet function study, and you're going to go to the guidelines, and the guidelines are going to recommend against doing this. But none of the guidelines will talk about these two strategies because the guidelines were written before this data. So the guidelines can be very confusing, and you have to know when guidelines were written to decide when you want to follow guidelines. So guidelines recommend against platelet function testing and genetic testing, but they don't have the data that is supportive of them. So again, it makes no sense the way our guidelines are done. So I shared that to say, look, the guidelines say don't do this, but it looks like it's a very reasonable thing to do, although the guidelines haven't caught up with this. So what is the summary in this with TicagrelowPrasugrel? Prasugrel seems to be preferred over Ticagrelor. Clopidogrel, guided by genetic testing or platelet function testing, seems to be just as good and with even reduced costs and maybe even less minor bleeding. So so I think our goal is to get people on Clopidogrel at some point in time. We can discuss when that is. Is that at hospital discharge? Is that at follow-up at 3 months? Or is that at follow-up at a year? We can discuss that in our next strategy as we get into DAPT. And my opinion is I'm reserving Ticagrelor only for those that can't take Clopidogrel because they're a non-responder, and they can't take Prasugrel because of TIA or stroke. So I think Ticagrelor is a strong third line. That's my thoughts on it. It's expensive. It has a lot of problems, and patients don't seem to benefit from it. All right, so to continue this theme, and let's see how much we get through this. To answer how to take care of patients in ACS, you also need to think about what is your strategy of DAPT after PCI. And we've been talking about ACS, but I think it's important to also throw back in all of PCI for this discussion. So here's the first thing that you got to know. Typically, we've given people a year of DAPT after PCI. But when you look at wins, and so why do we give patients Plavix, right? They weren't on Plavix when they got a PCI, before they got a PCI. They get the PCI and then they go on Plavix. Well, why does the stent, why putting a stent in do we need to put a patient on Plavix? And the reason is once a stent goes in, before you put a stent in, your risk of stent thrombosis is 0. You can't thrombose a stent that's not in your artery. As soon as the stent goes in, there is a risk for stent thrombosis. We all know that. And so we've typically given patients a year of DAPT to present stent thrombosis because that's what's in a stent. But when you look at when stent thrombosis occurs, and on that first year, you see that the majority, almost 2/3, is within the first month, and the vast majority within the first 3 months. And then it's really at a very, very, very low level after that. And so it's not like each month is equally important. It's really important in the first 30 days. It may be important up to 90 days. And then after 90 days, it's probably not important. The other thing is not every stent that goes in has the same risk for stent thrombosis. And today, if you get a stent for an elective outpatient routine PCI, and you look at your 30-day stent thrombosis on Clopidogrel, it's 0.2%, 2 in 1,000. It's almost non-existent. So you can imagine that all attempts to reduce a 0.2% incidence of stent thrombosis, you're not going to be able to show a trial to make 0.2 go to 0.1 or 0, right? Think about the trial size to move this needle. It can't be done. So don't look for it. It's not there. You're never going to find a trial that shows that elective PCI doing something will reduce this number. It's too low. You can't, the good news is it's so low, that's great. But the other thing is you can't look at data to say that this is going to move because of how low this is. Now, on the flip side, true ACS still has a 1 to 2% risk of stent thrombosis. That's not acceptable. We should not be accepting a 2% risk of stent thrombosis in our highest risk patients. So that we do need to still do better in this group. So not only is it the time that stent thrombosis occurs, it's also the setting. So early in 30 days in STEMI, very worrisome. Early in stable angina, elective PCI, routine, not so much. All right, I show you the guidelines, and my theme on the guidelines is know the guidelines and know when not to follow the guidelines. And the guidelines as a general principle are old. They're dated. They represent the past. Guidelines tell us what we used to do, not what we should do. So know the more recent data, know when to move beyond the guidelines. I really think all of you guys will join the ACC and become ACC members. We've got to advocate for the ACC and AHA to do a better job. We do a really poor job with guidelines in our community. They need to be updated yearly or even 6 months to stay relevant. This is a 2016, probably written in 2015. It's not relevant anymore, but I want you to see it so that you know the answers to guideline questions. Just as you also know, it's such a problem that when you write a test question for the boards, you can't say what's the thing to do. What you say is according to the guidelines. So they're not asking you what you should do to take care of a patient. They're asking what the guideline says, and that's because the guidelines are old and they get dated and they're out of date. So anyway, I say that to say you need to know guidelines because they're going to ask you questions that say according to guidelines, not according to what's the right thing to do, but according to guidelines. All right. So DAPT, the guidelines say 1 year of dual antiplatelet therapy for ACS, class 1. So that's where we are, standard of care guidelines. It's based on a 20-year-old trial called the Cure trial, probably conducted 25 years ago, where they took a lot of patients with ACS. Actually, the minority of them got PCI. Those that did get PCI had bare metal stents. Very different culture, very different world, very different technology, very different practice patterns. This represents almost nothing like we practice today. But compared to aspirin alone, DAPT did reduce the MACE, and so became our standard of care in ACS. Now, fortunately, what we've started to see is that there are now randomized trials looking at shorter courses versus the typical 12 months or longer. And what we can say is, with certainty, if you follow the guidelines, the question is, if you follow the guidelines, are we saving the lives of our patients? The answer is quite clear. The answer is, we sure aren't. We are saving 0 lives. So if you're a 1 year ADAPT for everybody person, you know how many lives you saved? 0. You do not save lives by giving a year of DAPT compared to either shorter or a year longer. Why not? Because all you do is trade risk. What you do is you may prevent a myocardial infarction by giving a year of DAPT, but you also create a bleeding complications, and these cancel each other out. And so we don't save lives. So a universal, one size fits all, I'm a 12 months of DAPT for everybody, that is saving nobody's life. So that's so unhelpful. It's just a unhelpful approach. The guidelines aren't helping. If you followed all the guidelines for all those years, think about all the patients we have not saved lives of. So a year of DAPT does not save lives. That's the first point. Now, the guidelines in 2016 for stable ischemic heart disease, or what's called chronic coronary syndromes, actually recommends 6 months, and it's a class 1 for 6 months. How many patients do you see get recommendation for 6 months after PCI? I bet it's rare. You may start to see it now, but it's been rare that you've seen somebody give 6 months of DAPT. But that's what the guidelines say. So we don't even follow the guidelines, which are also extremely dated. When you look at 3 to 6 months of DAPT, even at the time, this was 4 years ago, 4 to 5 years ago, this data was there, that short courses compared to long in stable ischemic heart disease had similar stent thrombosis, but probably less bleeding complications. So it seemed to be just as good and safer to give shorter courses. So the movement was to let shorter DAPT courses in stable ischemic heart disease, elective PCI, 6 months ago. Now, the community of cardiologists didn't follow that. They still like to give long. And in all fairness, I'm not trying to be unfair to the to us, to our community, but the reason that this all started was in 2006, the European cardiology guidelines suggested that when we'd just gotten our new first generations of drug-eluting stents, and we'd just gotten the first longer term follow-up, and it looked like we were having a lot higher stent thrombosis and that we were killing our patients with our first generation stents, drug-eluting stents. So and there was a lot of data, and there was a lot of look, and there was a big worry that the cardiology community was killing patients with first generation drug-eluting stents and higher stent thrombosis. And this led us to really intensify our DAPT therapy. So from 2006 to present, we got really, really, really aggressive. And so I understand how we got there, and it's important for you to understand why we got to be so aggressive with DAPT, but it was built on technology that's gone. You guys aren't going to see a first generation drug-eluting stent, so they're gone, and those days are gone. So we need to think differently. Well, what about long-term DAPT? I bet this is very common, right? So patients have had 6 months of DAPT or a year of DAPT. They show back up in your clinic, and what do? Most doctors do this. If it ain't broke, don't fix it. So they look and they see the patient. They say, patient, you're doing good. Everything's good. Yeah, great. Okay. Let's just not rock the boat. Refill. Hit the refill button. So most people are on autopilot, right? You come in, don't rock the boat. I don't want to change their meds, blah, blah, blah. So hit autopilot. You hit auto renew, and the DAPT gets renewed. And so that 1 year of DAPT becomes 2 years, and 3 years, and 5 years of DAPT. Well, what is the extended DAPT data? Well, the guidelines suggest it's a two-way. So they're not recommending it, although I think it's done a lot. They're not recommending it, but they're not recommending against it. They're saying it can be considered. If it were me, I'd recommend against it for the vast majority of patients. I'd make it a class 3, but the guidelines make it a 2B. This is built on the DAPT trial. So the DAPT trial was a big and important trial, almost 10,000 patients. They got randomized at 12 months to either coming off of DAPT or to staying on DAPT. So first thing you had to do well for a year. And if you were doing well at that year mark, then you either got randomized to staying on what we were doing, sort of that refill, just refill, auto refill. They're doing great, just refill it. Or the other strategy is, all right, they're doing well, but I'm actually going to take something off. And so they would take off the P2Y12 inhibitor. And they then watched them. And this got published in New England Journal. Very important trial. And if you kept patients on the extended DAPT, instead of taking them off, you got a benefit in the DAPT trial. And it was a modest benefit, but it was a real benefit. So there was a benefit to keeping patients on. What was interesting, though, is that this trial took a long time because it was so big to conduct, that the technology actually changed. And the technology went from the first generation of stents, for which we were really concerned about, and then changed into the second generation of stents that we currently use. And so half the trial used stents that we don't use anymore, and half the trial used stents that we use today. And when you go back and you look at the trial with the stents that we use today, there's no benefit to extended DAPT. This is MACE with extended DAPT versus non-extended DAPT, and there's really no benefit keeping people on it with contemporary stents. So back to the DAPT trial, it was driven by those first generation stents, which appropriately we got worried about, and it led to our current practice, but it led to a very aggressive DAPT approach. Technology changed. That aggressiveness is probably not necessary anymore, but our culture has not adapted to the shift in stent technology. So we still practice in a lot of ways like these were first generation drug-eluting stents, not our second generation stents. And if you look at bleeding, there's more bleeding if you leave people on DAPT than if you don't, and that's not surprising. And so when you go then look at almost 35,000 patients from 12 randomized trials, so this is only randomized patients, and you say, the strategy of leaving people on, are we saving lives? The answer is a pretty clear no, and in fact, we're shortening the lives of our population. So think about how many patients over the last 15 years, since the scare in 2006, have been placed on extended DAPT for at least a year, if not longer. That's become the majority of patients. And look, it's actually shortening the lives of that population. So the cardiology community, one way to look at this, has shortened the lives of our population over the last 15 years with our aggressive DAPT strategy. And now in an absolute number, it's not a big number, but you think about how many PCIs have been done over 15 years in the United States or worldwide, and it's a lot of patients, and a lot of patients are being left on aggressive DAPT therapy. Well, what about, is there a way to figure out which patients need this? And so one of those is the DAPT score. And so they went back and looked at the risks of who benefited in the DAPT trial and did try to differentiate it from, which types of stents. And they came up with this score that some things are negative, like if you're older, that's a negative. And then there's things that are bad, like having heart failure or vein graft PCI. And so you add up these things. And what it shows is the reason the cardiology community is harming patients as a whole is that patients with a low DAPT score are clearly being harmed by being left on DAPT. So when you look at low DAPT scores, DAPT versus single antiplatelet therapy, it didn't improve outcomes, and it leads to a lot more bleeding. And because there's harm without benefit, there's more death. So the way I think of it is, if you are gonna write a refill prescription for DAPT, you better write down the DAPT score and make sure that the DAPT score is not low, because you're harming the population as a whole by giving this group, all you're doing is causing bleeding and death, and you're not helping. Now, if your DAPT score is elevated, should you refill that Clopidogrel? The answer is maybe. It's not as clear. Well, I still don't like it, but at least in the DAPT score world, it makes sense, because those that were left on Clopidogrel had less stent thrombosis and MI, and it didn't seem to increase bleeding. Now, interestingly, whereas in the first slide, a harm without benefit led to increased death, benefit without harm did not improve death. So we don't have any data that lives are saved with extended DAPT. But at least this group looks like a benefit is more than the risk. So at least there's a rationale of giving somebody. So my takeaway is, the first takeaway is, if you think somebody needs to stay on DAPT and you're going to hit the refill button in your clinic at the whatever 6 month or year mark, you better do the DAPT score if you're going to hit refill. So because you should take away the patients who are not going to benefit, and it's a lot. It's over half. So 55 to 60% of your population is contraindicated or should not get it. Wow, this might be a good place to stop, and maybe we'll take over next time. Instead of launching into this, I think that the data is really setting the stage for what is, I think, going to be the standard is shorter DAPT. And we'll go through this next time, but our move is to start doing 3 months of DAPT for most patients. And we'll talk about why, I guess, next time. Maybe, I think this is a good place to stop, because I think if we use the next 8 minutes to get into this, we'll only get confused. So maybe we'll cut early, and let's use this as a time for any questions regarding ACS. So anything about STEMI, GPIs, non-STEMI, Clopidogrel preloading, Prasugrel versus Ticagrelor versus Clopidogrel. Any questions?
Hey, Dr. McDaniel, Terrell. I was just wondering, I mean, as far as like the genotype testing you're talking about, how have you seen it, like a time versus like the time that it comes back? Is insurance at all helping at all to cover it? Like, how practical is it?
So it's a great question. So there's what we want to do, and there's what we have currently. So currently, we don't have a good genetic test in the system. So you can't, first of all, if you're in the inpatient setting, do not order it inpatient. In the Emory system, Grady system, it's a do not do. The reason is our genetic test requires it to be sent off. It goes to an outside lab, and it takes 2 weeks to get back. So in our current workflow with our current tests, it's not a good strategy to do genetic testing today. With that said, we are working to bring in the Spartan genetic test. So this is what we want, but do not have. The Spartan genetic test has a 1 hour turnaround, and it's a buccal swab, and you can get the results back in an hour. So where we'd love to go is to genetic test all of our ACS patients, and we'll go into whether we genetically test the elective population. That's a controversial thing. We'll talk about that a little more next time. I want to show you the data before we talk about it. But we can get to the point where we get genetic testing in-house. So where I'd love it is you come in, you use Prasugrel in the cath lab, you send the patient to the floor, you order a Spartan genetic test, you get the test result back within a couple hours, and if they're a responder, you reload with Plavix and you send them home on Plavix. That would be the best for patients. We're not there yet. So today, the two options are you either put them on Plavix and test their Plavix with platelet function testing. The problem with platelet function testing, or Verify Now, is you actually have to give the Plavix to test the Plavix. So you have to treat a third of your population in which Clopidogrel doesn't work really well with the drug that doesn't work really well. So that's the problem. So some people don't like giving Clopidogrel for that reason, because then you have to test it. And you have to give it to test it. So the other approach is just give everybody Prasugrel. It's now cheap. Get them through 90 days. And as an outpatient, test them genetically, or switch them to Plavix and test them phenotypically. All right. See you next time. Thank you.
The preceding program is copyrighted by Emory University.